Hello, welcome back to the Autistic Tidbits and Tangents podcast. I am one of your hosts, Cara Diamond. I'm an autistic teacher, university lecturer, and author from Toronto, Canada.
Hi, everybody. My name is Bruce Petherick. My day job is I'm the autistic advocate at Autism Canada. And previous to that, I was a musician. And for some reason, recently, I've been dragged back into that world. Mm-hmm. Oh, and I'm in what I normally say is sunny Vancouver, British Columbia, but we actually have a little bit of snow and the world is ending, according to people in Vancouver.
Yeah, we have snow here too, but we're used to it in Ontario. Now, by the time this airs, everyone's going to be surprised because it'll probably be springtime. So we're recording in January, just for everyone's awareness. All right, we're really excited. A couple of weeks ago, Bruce got me talking about sleep and, how I have difficulty sleeping. Another friend of his who's autistic has difficulty sleeping. And we thought we need to get someone with expertise on this topic. And it was not very long before a Google search introduced us to Dr. Neff. And actually, I was familiar with Dr. Neff already, having seen many of your infographics. Let me tell you a little bit about Dr. Neff. Dr. Neff is a neurodivergent psychologist and founder of Neurodivergent Insights, where she creates education and wellness resources for neurodivergent adults. She's co-authored 2 books and is the author of the forthcoming book, Self-Care for Autistic People. Doesn't that sound great? Additionally, she has published several peer-reviewed journal articles. So driven by her passion for accessibility, she translates research into visual pixels, which I love, which you can find on her website and Instagram. And I will post the links to that in the show notes. But her handle is neurodivergent_insights. And she also co-hosts an amazing podcast called Divergent Conversations. So you should definitely add that to your listening preferences. So welcome so much, Dr. Neff. It's great to have you on.
Thank you. It's great to be here. Thanks so much.
We will be picking your brain about all things related to sleep.
Please do. Please do. It's a topic I find rather fascinating. So I'm here for all of it.
Yes.
Welcome to Autistic Tidbits and Tangents.
Candid conversations between autistic off-hour professionals.
With lots of tangents in different accents.
Cool.
Trigger warnings for this episode include internalized ableism, as well as ableism and ignorance in medical settings related to neurodivergence. All right, so I'm so curious, first of all, to learn a little bit more about you, why you are passionate about sleep, particularly in relation to neurodivergent folks.
Okay, I don't think this is a fun story.
Yes.
I'm still working through the scripting. So I scripted through what I might say and this story didn't come up. So it's like you're getting the unmasked organic version.
I love it.
So when I first discovered I was autistic, which was at age 37 after one of my children was diagnosed, such a classic adult story.
Yeah, gateway.
But I started Googling everything weird I'd ever experienced to figure out if it was at all connected to being autistic.
So and relatable.
Right? Because autism for a lot of us, I know for me, it's becomes this kind of meta narrative that explains all of these things that we thought we would never get a narrative for.
Exactly.
And so, from why can't I open peanut butter jar lids to why is my sleep so terrible? I was Googling everything.
I can't open peanut butter jar lids either.
Well, there's a reason.
I want to hear the reason. Sorry to interrupt the story.
Firsthand.
Yeah, no, the reason it's interesting because I didn't necessarily relate to this. Before I got long COVID, I was pretty athletic, but it has to do with, oh gosh, I don't like referencing research when it's not top of head. So this is fuzzy
We
research.
will not hold you to it. Don't worry.
Okay. But something about like muscular, like tendency to have less muscular
tone and things.
Tone. Yeah.
Okay.
Yeah. So connected to that.
That makes sense.
Mm-hmm. I would think proprioception could also be involved, like not knowing how much force to apply.
Proprioception is my new solution to everything. It quite honestly, it hit me, read some research 8 months ago as part of one of my teaching programs. And I suddenly thought, wow, proprioception is a cause for a lot of stuff going on. Mm-hmm. Sorry, I interrupted, but that's
don't be. I mean, it's divergent, right? And like, I agree. I think that's what's so powerful about a later in life discovery, not just the autism or the ADHD, but then like all these fun rabbit trails of proprioceptive, interoception. Oh, that explains this. Like these things that just we thought were diffuse and weird and hard. It's like, oh, there's actually a reason.
Yeah, little disparate things that just didn't make sense. Suddenly you have that explanation. You have that through line.
Yeah, which is so powerful, especially if you think about like the autistic brain and uncertainty.
Yes.
Increases our anxiety and stress. So when we can be like, actually, this scientifically makes sense. And here's why, like, that's really soothing.
And I think a lot of self-forgiveness comes with that for things that, maybe we were blaming ourselves for, that internalized ableism before we even knew, what that meant. Yeah.
Absolutely. Yeah. So much. I often say that identification can unlock a lot of self-compassion or gentleness for the first time for a lot of us. Absolutely. Yeah.
So in your story, you couldn't open peanut jars and you were doing research and all those weird things. And I'm finding this amusing because it's like, how do you define what's weird and how to define what's not?
Well, and sometimes you don't know something's weird until someone says, people can't open peanut butter jars. It's like, oh, I can't.
That's a really good question. Like what's normative? I mean, and even like I've seen more and more questions of even like neuronormative culture. Is that actually normative or is it just how society is built, right? Yes. Like, is that actually what the largest bell curve under the umbrella bell curve? I'm messing up my words, but like, is it actually normative? I think that's an intriguing question.
And I think if we were to actually bell curve something and line up the number of people who do whatever that normative thing is just naturally, I think it would not be normative. I think most of us are sort of outside. Anyway, that's
it's I'll be interested, like, as we learn more and as more comes out, like, how normative is neuronormative. Our systems definitely are, but in a population, but we are diverging way off. So sleep.
Yes. Back to sleep.
So sleep was like probably one of the first things I Googled, from things like sleep paralysis to sleep issues. Cause I've always, like as a child, I slept walk, I had night terrors. I've always struggled with insomnia. In my course of therapy, I'm a psychologist and most of us in training do pretty in-depth therapy. I was actually exploring the possibility of repressed trauma because so many of my diffuse experiences, the only narrative we had in the mental health field that made sense of it was trauma. But I don't have a significant trauma history. I mean, outside of like being autistic and all of the trauma that comes with that, but not in the classic sense of what we would consider like complex trauma or developmental trauma. And so I was exploring, like, do I have repressed trauma? Like I was experiencing all these things at night, like, or as in childhood, including all these sleep issues and anxiety. And so that was part of my discovery process, realizing actually all of these experiences clustered around autism, not trauma. But one of the things that was like that red flag for me was how I slept as a child. Like it just, it was a very dysregulated sleep that you would sometimes see if there was a child who was experiencing trauma.
Yes.
But now it's like, oh, that's actually a lot of that can be explained partly by my autism and my ADHD. So that was a pretty big eye opener for me. So it was one of the first infographics I actually created was autism and sleep.
Yeah. Wow. Okay.
You're actually, sorry, Cara, go on.
No. Oh. You first.
Proprioception. It's interesting. I'll come up to my finer point about sleep much later, but you're reflecting actually somebody deep and close and personal to me, aka is my wife. She has ADHD, and you're describing actually her sleep patterns. And she just thought that's what she was dealing with, and she actually had thought about trauma, funnily enough, herself too. But then when she was diagnosed, the doctor said, your sleep issues are probably caused from ADHD for a whole bunch of reasons, and she's on a pretty medicated regime, and her life changed from actually having a good sleep.
That's amazing. Can you give me her regime?
Exactly.
Could you put that in the episode notes? I want her secrets.
It may involve things that are legal here, but not legal everywhere in the world. And
now, okay, Bruce.
Well, I'm in Oregon, so we've got some things that are legal here.
Bruce, what's your sleep like?
Well, okay, so this is my subtle point. So we'll need to, we're going to parenthesize and get into like multi-level conversations now. We'll roll back later. The original thought for me, why we got on this pattern, was, as Cara said, I have a very good friend who is now diagnosed with sleep apnea. But before that, he just thought that everybody slept 4 hours a day at night. And so your question to me is, how's my sleep is I have no idea. Like, I never had sleep terrors, although I do woo-woo, as my family say. I have these nightmares where I yell, which happens a little more frequently than I think is normative. Anyway, but I never sleepwalked. I never really had insomnia, yeah. But I have no idea what normal sleep is. It's just what I experience.
Mm-hmm. And I've always had bad sleep. Like as a child, I was always and I still am very sensitive to any light, any sound, any noises. Like I'm a hypervigilant non-sleeper. I don't know if that makes sense. And I remember I would never sleep if I had a sleepover with other people, partly because I was afraid what would happen. Like, are they going to draw on my face? Like, what's going to happen? But also, even like a friend that I really trusted, I knew they were there. I could hear them. Maybe they wanted a light on and I wasn't comfortable with that. I just could never. And I fall asleep easily, but then I wake up probably 10, 12 times a night at least, and often for like an hour, a long block of time. This morning, I woke up at 4 and I decided to get out of bed at about 5:30 because there was no point just lying there. And it doesn't bother me anymore. Like I'm not there ruminating about not falling back asleep because I'm used to functioning on not much sleep. And there is something peaceful about an early morning that is just your own. So it's like, it no longer is like stressful not to sleep. There's a peacefulness about, I don't know. So that's like a competing need to have a time that is just my own.
That reminds me of something I said. We actually did an episode on sleep on our podcast. Mm-hmm. Mostly Patrick and I were just whining about our sleep, but we shared some sleep research too. But one of the things I said on there that came from me thinking out loud was like, I think a lot of us need to heal our relationship to sleep. Like if we think about sleep, of us like having a relationship to it as an entity, because a lot of us have a stressful relationship to sleep. So I love how you describe kind of reclaiming your morning, because like you very much could wake up with like, oh my goodness, I woke up at 4 again. And then that energy can carry over. Yeah. And actually, so our brain is really good at creating associations. So if we have a stressful relationship to sleep, that's going to carry over to our bed, which is then going to activate our stress. And then that's going to make it harder to fall asleep. Yeah. So, I love how you describe kind of reclaiming your relationship to sleep, even though it's not ideal, because that's actually one of the things we need to do to be able to improve our sleep is have less stress in our relationship to sleep.
Mm-hmm. I traveled not long ago, and my partner said, like, aren't you jet lagged? No, this is like my norm. I always feel like this. So that wasn't a problem for me. And although I think I was jet lagged because I did have 2 great nights sleep in a row where I dreamed, and I haven't dreamed in years. Like I just don't get into, I don't know if that's like a deeper part of the cycle.
Yeah, no, there is some research that shows, I think it's autistic people on average spend about 15% of our sleep cycle in REM sleep compared to allistic or neurotypical, because ADHD too. Neurotypical folks tend to spend more like 25% in their REM sleep. So that is one of the findings, is that we tend to sleep less and we tend to get less quality sleep. So we kind of get a double hit there.
And why do you think that is?
Oh, I think there's so many reasons. Do you want the bullet?
Yes, please. Okay. Give it to me.
So Bruce already mentioned one, which is sleep apnea. And actually Mel Hauser, who is an autistic physician, does a great job explaining why from like a medical, like I just knew that there's a higher rate of sleep apnea, but they actually explain how it's connected to, I think, connectivity and other medical conditions that a lot of us have. But so sleep apnea, a lot of us have that, or other sleep obstruction. Other things that can factor in, like you already mentioned, Kara, would be sleep sensory sensitivities, just that really high sensitivity to light or sound or texture. Like if we can't get comfortable, that's obviously going to interfere with sleep, both sleep onset, but sleep quality. Things like, okay, let me look at, I always mess up how to actually say this. No problem. Circadian rhythm sleep-wake disorder. So that's when we have a mutation on our clock gene. Our circadian rhythm can be kind of different than what is normative. Normatives are like word of the day. So for example, these are folks who maybe don't get sleepy until like 2 a.m., but then maybe they have an 8 a.m. job they have to wake up for because their circadian clock is off of what kind of the sun and what neuronormative work and education run off of. Another reason, again, due to genes, a lot of us have what's called a flattened melatonin curve. So we might not experience that onset of tiredness at night in the same way. And then there's lots of studies that just show we're more likely to have insomnia. I think some of that is genetic based. And then I think sensory sensitivities, busy minds. A lot of us have really busy minds that like to ruminate at night. And so that can absolutely keep us up as well. And
then I watch like mindless shows sometimes, and then I'll have a break, but mindless shows turn off the brain chatter.
Yeah, absolutely. Absolutely. And then parasomnia. So that's things like sleep waking and sleep paralysis. We're more likely to have those as well. So that's the bullet list.
It's interesting we talk about circadian rhythm because for most of my life, I had a job, because music is a job, right? Where I'd be working at night. And up until the age of mid-40s, let's say, from my mid-teens, I did not go to sleep before midnight, like at all. And rarely, but sometimes I had 7 o'clock rehearsals, not 5 days a week. And now, as I've gone a little older, it's a struggle to make it to midnight, but I'm still an 11 o'clock sort of person. But it's kind of interesting. It's like, have I shifted my circadian rhythm or did I fight against it the whole time? It's something I've never, and because I've also, part of my job was also traveling. I did a lot of touring. Like, what circadian rhythm? Is it the one back in Melbourne in Australia where I'm from? Or was it, in London where I was, performing? Or it becomes, that's always been an interesting thing for me. And I don't remember dreams except for rare circumstances.
Yeah. I also talk in my sleep, and some people might say I snore. I might even, because I've woken myself up.
Actually,
No,
is snoring tied to autism? Do you know that?
apnea?
I don't know that it's tied to autism. It is tied to like sleep obstruction or breath, like breathing obstruction. It doesn't mean that you necessarily have that, but it is connected to that, and then that's more common among autistic people. So like you could indirectly make a link, I would think.
Yeah. I think it was non-causative, because I was like, I suddenly thought, no, a lot of people I know, autistics I know, say that they snore, but yeah, okay.
Okay. And my father has sleep apnea. I was like, I have all these sleep issues. I should go do a sleep study. And in the province that I live, it's fully covered once per year. So I went 2 years in a row to do a sleep study. The first time that I went, it's so uncomfortable. You're in a different environment. Like, because of their fear of like things like bed bugs, you can't bring your own pillow, you can't bring things like that. You're hooked up, you can't move. I'm someone, I do toss and turn, and again, as I've said, I have all these like sensory issues at bedtime, right? So I didn't sleep enough for them to observe anything. Like, they said, like, based on the amount of time that I slept, they probably assumed that I had a higher level of whatever they were measuring. Like, but I didn't have enough sleep that they could say definitively that I have sleep apnea. So they recommended I come back the next year. And it's like, I came back the next year and the same thing. And then with my phone call with the doctor, he just said, like, don't just keep coming. Like, it's not going to work for you. Like, we're not going to get the data. So it wasn't until I had a conversation with Bruce, I took that literally and went, I guess they'll never know if I have sleep apnea. And Bruce said, like, I don't like, there are probably other things you could do or other ways you could investigate it. So that's my sleep apnea.
Did you find some alternative ways to investigate it? Because I would think so many autistic people, I don't think I'd be able to sleep in a sleep study. Like, I think so many of us would struggle with that.
What else is there? Like, do you have any idea, especially for neurodivergent people? Like, how can we?
Someone, how they're like starting to do like colonoscopies at home? Like, I've seen, well, I've seen advertisements for it. I haven't like looked into the literature at all. I'm just like, oh, that's interesting. I don't know how reliable they are, but it'd be nice if someone invented like a sleep apnea test you could do at home.
Yes.
I feel like with so much change coming to like the biomedical world that I won't be surprised if we see that in the next decade. Maybe that's wishful thinking, but that'd be nice.
The Apple Watch, I know there's so much that people are doing with Apple Watches. There's got to be data on an Apple Watch, or I'm an Apple person, so insert whatever device you want to talk about here, that could record oxygen intake and sleep and movement. And there's got to be enough correlative data in that. There has to be, I would think, at least to sort of say, this is 75% likely or 98% likely.
Yeah, that would be amazing. I feel like, because sleep apnea is something I've looked into, like it doesn't happen often enough, but when it happens, it's so disconcerting. But maybe a handful of times a year, I'll wake up choking, and like I have to cough to breathe, and which is obviously that's like very consistent with sleep apnea. But I haven't gone in for a sleep study, partly because it's like, well, that only happens. That's probably bad logic on my end. Anyways, enough that I feel like I saw something. This might not be accurate, but I feel like I saw something about some way to detect like maybe higher probability from home. I'm going to look into that when we're done recording, because that would be amazing if that did exist.
Well, and even if there's nothing yet, I've been thinking about, like, how do we advocate within the medical system for, well, if we can't successfully complete the test, like, can't we do some sort of differential, like, just give me a CPAP machine for a trial and let's see if my sleep improves, but all of those things cost money. Neoliberalism, our favorite ranting point. But it would be great to have other approaches.
It would. It really would. Yeah. Yeah, absolutely.
Now,
we've talked about the medical system quite often on this podcast, and I'm doing a large number of projects at Autism Canada about huge problematics when it comes to the healthcare system. But it comes down to it's something you just said, like you only have a possible symptom of sleep apnea once in a little while. And I think I'm the same way. I think it happens once every couple of months, let's say. And so therefore, because I'm autistic and I really don't understand what my body's doing anyway, I just think that's what everybody's doing.
Mm-hmm.
And that's the problem, isn't it? It's like until we learn more about ourselves, the interoception of personal interoception, but then also start then thinking, is this normal? Is this whatever that means? Or is this something I need to investigate? Or is this just whatever?
So I just got super excited.
Yeah.
I love this topic thread because I think it also connects to masking, right? Which is a survival strategy for a lot of us. We learn to betray our needs by masking. We learn that hard and discomfort is normative. For us, that's our normative experience. So I think then we don't know what to do when we are having symptoms of discomfort. We are so used to invalidating our own experience of discomfort and overriding it, that teasing out what is something worth going to the medical doctor about, it becomes really hard. It's hard to be an advocate for ourselves when we've chronically invalidated our discomfort and pushed it down as a form of survival. I certainly struggle with that. And then throw it for me, and I think a lot of autistic people have health anxiety. I definitely have. Then it actually leads to more medical avoidance because I'm like, well, but maybe they're just going to tell me I'm anxious, or like, this is probably me being anxious. So like, I've actually got a lot of medical stuff going on right now, but I've been so bad about getting in to actually seeing doctors. And I think it's so connected to all of these things.
And then I will take things literally, like my doctor wants me to only bring up one issue at an appointment. So you don't know what's connected, right? So you don't always give them the full picture. And even when I went for the sleep apnea tests, I don't remember if I was diagnosed the first time, but for the second time, I knew for sure I was autistic. I didn't say I'm neurodivergent. Would that have skewed results in any way?
Do you mean like provider bias results, or
is that something that's
like
important to disclose to the sleep study analysts?
So this taps into that bigger conversation, right? Around like, is autism in your medical chart? How do you want it in your medical chart? So like, I think first a person would have to sort out the risks and benefits of having that in their medical chart. Which is kind of a separate conversation. Then, so say you are comfortable with that. I mean, I would like to say, and in an ideal world, I think that's incredibly helpful context, right? Like, and to even be able to say, I'm autistic and ADHD, and I know there's higher prevalence rates of these things. So these are the things I'm wondering about. Like, that would be really helpful, I would think. That also assumes that the medical provider, like the medical provider might not be up to date on neurodivergence and prevalence. And then you also don't know how they're going to take that in. In an ideal world, that would absolutely be helpful context, because we do know there's a higher prevalence rate of lots of these things among us.
I certainly, I have a very, very, very strong opinion about this, in that it should be disclosed. And I thought, for my friend specifically, I actually told him he was going to see the doctor again. And I said, you need to tell them you're autistic, and it was because we don't do pain scales very well.
Yes.
And your masking perspective is exactly the same thing. It's like, we will not say things that we think are important, or we've masked, or we can't even feel it. And so the medical profession need to dig that information out of us a bit more. And it's kind of interesting. I've never I actually studied to be a doctor when I was quite young. That was what I was doing as an undergraduate first time. I would be a terrible doctor, but it's always been an interest for me. And so I am one of those rare autistics who's actually happy to go to the doctor because it may be one of those little special interests. But when I'm really sick, my wife has to come with me because I will forget.
Mhm.
I will forget to say I've had a I've had a 39-degree fever for 5 days. And it's like, that's kind of really super important for the doctor to know. And I'll just forget. And, you've raised it. Yeah. I'm glad you said masking because I don't think I ever really thought about it, but I've probably masking.
Mm-hmm. Mm-hmm. Well, even I'm thinking you sort of alluded to this too. So even if one is comfortable disclosing diagnosis with a medical professional, it comes down to their knowledge and understanding, yep. And they might not have the background for how, these populations are affected by different things. And that can be really difficult. Like I find sometimes, and I love my doctor, but my doctor doesn't know very much about neurodivergence. And so I still get told things like, oh, but you're so high functioning. And I have to go don't mistake the fact that I can articulate what's going on with me and that I have high self-awareness for not struggling in any way, However, he is someone who's very open to me coming in with a whole bunch of research and it does not have an ego in any way, which is really, I think I can work with that, and come in and do a little bit of education. That's fine. But not everyone's comfortable doing that. Not everyone has that type of relationship with a doctor. So this self-advocacy and all of these things is it's so difficult.
It's so difficult because it really is. You don't know who's on the other end of that self-advocacy and how they're going to receive it, how much information they know. Yeah. Yeah. It's actually on my wish list of activities to do this next year. I really want to make self-advocacy kind of PDFs. So if it was a 1-page, I'm autistic or I'm ADHD and I have sleep issues and you're going to, and it's a bullet point of the research, something you could hand to your provider and be like, here's things I'd like you to know about what this means. I have a lot of my ADHD brain. I have a lot of wish list tasks, but I really would love to do this because I think having a 1-page printout of peer reviewed research that you could just hand to your provider, I think would be really helpful. Because there's so much variance in how much knowledge medical providers have about this intersection.
At Autism Canada, we actually literally today I started the final part of our project we have a guide for cancer patients, autistic cancer patients.
Wow. So cool.
It's written for the patient, but it's all about how to get the information to the doctor or the nurses and things. And we are working with this is an autistic person who is on the final stages of her cancer journey, unfortunately, and her sister, who's been her supporter, and they've written the guide together. But because we've got so many other cancer groups looking for similar sort of things. So you're articulating exactly what we've got. I've never even thought about the sleep thing, which I think that's fantastic. Come on, send me an email at my work address and we'll
I'll
talk.
I'm so interested in this because I used to be a psychologist in an oncology clinic, and oncology and oncology care became a special interest during that time. And I actually wanted to write because I was learning all about behavioral approaches to supporting oncology patients. And I wanted to write a book on oncology care. But then I thought about we know autistic people get cancer at higher risks, and I don't think we have a lot of resources. So I am yes, please let's follow up because I'm really interested to see that guide. I think it definitely needs to exist. When I look back at my time in the oncology clinic, now that I didn't have the lens for autism back then, but now I'm oh yeah, there were a lot of autistic patients that came through. And if you think about the uncertainty, the change, the sensory experience of chemotherapy or radiation therapy, oh my goodness, yes, we need autistic resources for that.
Cara, we talked to Kristen.
Kristen, yeah. COVID.
So another person we interviewed, she works within the system. She works at a hospital here in British Columbia, also autistic, and she's seeing the internal problems for autistic patients. So that's something else. That's another little project working on. I want to go back to something you said about the self-advocacy, and it's interesting. I'm reading a book, and I'm gonna just say this book over and over again for every time anyone talks to me in the next couple of months. That it's a series of 2 books actually called "Is This Autism?"
I love this book. Donna Henderson and I, we're friends, and I when I read that, I was like, how can I get this in every training program? And I reached out to the publisher. I was like, can I pay to give this book away to training programs? So it's the most validating book I've ever read, because it brings together the peer-reviewed research in a way of that medical providers can't be they can't discount it. It is so robust and so inclusive. Sorry, I totally just interrupted you.
No.
But I love that. I love that book series.
I'm getting teary. I haven't read it, but I've heard such good things, and it just makes my heart so full.
Go read it. It'll be the most validating weekend of your life. And I actually don't read much anymore, but I read it in a weekend. Also, I just said Donna Henderson's name because that's the person that know her the best, but there's 2 other authors, Sarah Whalen and Jamel.
Yeah. It's a name that I wouldn't pronounce because it's
I think it's Jamel White. I want to get
Google
that right.
that now. Sure.
Yes.
While you're looking that up, are you talking about, so there's two volumes. There's one for, it's supposed to be both for the medical professionals, but one's basically people on the street. The second one's very specifically about how to diagnose. And the diagnosis one was one I was just going to bring up. She talks a lot about self-diagnosis and a diagnostic, a person who, a diagnostician should be aware that somebody who's self-diagnosed possibly knows more about autism than the diagnostician does. And I thought that, and even for that to be written in such a book is again, so wonderful.
Yeah, absolutely. Yeah. I mean, if you think about the autistic experience, the average autistic person, we don't self-identify lightly. Typically it's through hours and hours of research and reading. And that was my experience, so I first self-diagnosed before an official diagnosis. And I was shocked to find there's so much peer-reviewed research out there that's talking about masking and talking, back then the autistic female phenotype, obviously we've moved toward less of a binary when we talk about phenotypes. But I was blown away that research was out there, and that as someone with a doctorate in psychology, I had no idea it existed.
Yeah. Well, because we're in our little bubbles of our niche, where we are situated. So coming from education and doing my doctorate in education, all of the research I was pulling was articles that first of all used person first language, things like that. That was the sphere I was in. I didn't know all of these other things until I started to really investigate, my own experiences and come across my discovery, and that, shifted a lot of things. Yeah.
Your book is still, you always bring up the old research, but the best parts about your book are your stuff, your experience in the classroom. And I quote you all the time at work.
Thank you. Bruce, just so you know, Megan, Bruce read my book, which I wrote knowing I was neurodivergent, but not really knowing the full extent. And it's called The Autism Lens, because I've worked with autistic students my whole adult career. My brother is autistic, and I knew that growing up, though I didn't know about myself, though I suspected a little bit. But he's got it there. Bruce said to me, he befriended me. We had a lot of back and forths on social media, in our direct messages. And eventually he was like, do you think you might be autistic? So he's like, no one could write that book, even though it does mix person first, identity first. There's a few things I would change in light of my own diagnosis, but he was like, you would not have been able to write that book if you didn't deeply, deeply relate.
So this is an interesting, okay, maybe we should have you on our podcast to talk about this because this is a pattern I see a lot. And I really would love to understand the like identity experience of the sibling, where when there's siblings and when one presents that more stereotypical autistic phenotype or is more classically impacted by their autistic traits, and then there's a sibling who is non-stereotypical presenting, that can make it harder to identify because it's like, this is what autism is. It's what my sibling has.
Yeah.
Or that was an interesting use of has, I think, because in that it's
that
often
context.
talked about in that way. And so then the non-stereotypical sibling can go years and years,
Yes.
Both with the psychological experience of having a sibling, a disabled sibling, right? There, we know there's unique experiences around that, but then also being autistic and non-supported, and then it being harder to see it in oneself. I think as we're coming to understand non-stereotypical presentations, we're seeing more and more of those siblings self-identify. And I think there's going to be a lot we learn around that complex identity journey because it's a great different path.
Yeah. Yeah. And what is interesting, like I will say, I think my late diagnosis was difficult in some ways for my parents. Cause like, they're like, did I miss something? Did we not support you? And I was like, no, you did a great job. Like, it's fine. My brother was like he totally was not surprised at all, which surprised me a little bit because there is that, sense of, you feel selfish sometimes seeking a diagnosis when your needs are maybe not as apparent. They're different needs. I have a career. I don't have my life together, but it looks like I have my life together, in a lot of ways. And, but yeah, my brother was completely nonplussed and not surprised either. So
your brother probably, I do actually hear this. Yeah. I hear this all the time with clients is that you talk to another autistic person, and even if you don't know they're 100% diagnosed or whatever, there's suddenly this connection because there's a use of language or a use of perception of the world or whatever. And it's just like, oh, I'm comfortable with you. Yeah, good.
And I probably my whole life, he's been the person I've consistently been unmasked with. We don't have to say anything. Like we can just sit there, and be our little oddball, wonderful selves together,
Well, and I think for a similar reason of what you're both saying, another pattern I see is a lot of folks who don't know they're autistic will go into fields of working with autistic children or working with autistic teens. Again, because there's a shared neurotype there. So they're finding ways to work where they're not having to work cross neurotype, with different neurotypes. And I think it's so interesting how we intuitively find that. I think it really is a powerful testament to how strong that connectivity is when we're interacting within our own neurotype. But
even look at what we're doing now, we launch into conversations and we go deep, we're not doing all the chit chat, though I can chit chat. It's not my favorite thing. I much prefer to get to substance,
Yeah.
We did talk about the weather.
Minutes.
Yeah.
Sorry.
We did talk about, you're right. We did talk about the weather.
True. Yeah. Have you all referenced on here, Milton's double empathy problem and Crompton's follow-up study?
Crompton's follow-up study. I talk about it all the time.
Yay. Yeah.
Actually, just remind me about what's that one?
That is, why don't you know?
Oh, go ahead. Go ahead. No. Well, now correct me if I miss it. But they wanted to, Milton created the theory of the double empathy problem, that it's not the autistic person that has the deficit, it's that bridge. And then they were like, well, let's test this empirically. So they paired people in cross neurotype interactions. So like autistic and autistic, autistic, non-autistic. And they had them do a series of different exercises. Like one was they were doing a project together. I think one was some sort of conversation based. And then they rated each other after on rapport. And the neurotypical pairings had the highest rapport. And then the autistic had the second highest, and the lowest was when it was across neurotypes, so neurotypical and autistic. One really interesting finding, they then had it like a second part of the study where people watched the videos and they rated the interactions, and the people watching actually rated the autistic to autistic conversations as the highest. Like it seemed like they were getting along the highest.
Interesting.
And so but if you're going on the deficit model, you would assume, okay, you bring two autistic people together. They both have social communication deficits. They're going to have the lowest rank because there's no neurotypical there to like help, help with the communication. Propel it along. But because that's not what's actually happening, it's communication differences. We see that empirically, autistic people connect well with other autistic people.
And one of the best things they did, Bruce, so they almost played broken telephone with the three groups.
I remember
one fully autistic group, one fully non-autistic, and then one mixed group. And like the two homogenous groups had very similar outcomes. And one of the things they tracked was how many details they remembered, as well as the in-group rapport. And they were similar, those two groups, but then the mixed group was where it all fell apart. They remembered very few details, and they all felt like it was not a good experience for anyone.
How do we like move that into an assessment? Like where you have a group and it's like, okay, which I would love community elements to assessment.
That would be so
do you
wonderful.
Connect with autistic culture?
Yes, exactly.
Walking into a therapist's office, and there's three people, and like, which one do you just go to? Oh, yeah, right, you're autistic. Yeah.
It's like the sorting hat in that book series that should not be named. Sorry.
That one about the child Harry Potter, that's the one. Yes. I'm always I did remember. I couldn't remember the person, the author's name. So yes, I did remember the study. It actually I actually think autistic to autistic communication in those situations would be higher than neurotypical to neurotypical, because yes, we may lack some social skills and social communication skills, but it means if there's a task, we can just do it. And we don't have to worry about the fluff around
and we
there.
We go right into like the essence of it. I often will say I don't feel like I have social ligaments, like moving into a new conversation, adjusting, like saying hello, saying goodbye. Like I really struggle with that. But once we get into like the muscle, and we're going, it's like, okay, I've got this. So yeah, I would think in autistic communication, like we get to the essence in a way that I think, frankly, is incredibly meaningful and beautiful. And that, like, I feel so, well, I guess I am autistic, but like, I think, like, I feel so much more meaningfully connected after an hour with autistic people. And I think if you looked at what was being talked about in that hour, that it would be more substantive for the most part. I don't want to say that too strongly. I try to avoid hierarchy of saying autistic people are better than non-autistic people, but I do think we tend to have more substantive conversations.
Well, and it's like we have a preference of communication. We tend to be more direct. We tend to go deep into things. So I think that's more of a preference rather than a hierarchical, like what is better, right? It's
and maybe I hadn't had this thought before, but like I wonder if it's also like an energy preservation thing. Like I talk about how I feel like I live my life on low battery mode. And so if I don't have a lot of energy to just like be absolutely blanking on the word, but frivolous with, and I'm going to use, especially social energy, like I'm going to use it intentionally. And so I also wonder if going straight to kind of the substantive conversation is a way of energy preservation.
I love that.
Actually, Cara, you and I have talked this week about how you and I are low energy at the moment. You're struggling with a whole bunch of different regular human things.
Yeah.
But how you and I both suddenly find talking 2 hours on a podcast absolutely like nothing.
I'm feeling like so much more energized now than because I find conversations with people that I relate to, like I find it very restorative and regenerating, which is not true of all conversations. So
I relate to that. Absolutely. Yeah. I think I also feel more energized than I did an hour ago.
Yeah, good.
So we've solved the world's problems. It's just let us do what we need to do by ourselves and everything will be okay. And, yeah.
But we haven't solved sleep problems yet. So
right.
What do we do? Like what? Okay. I should preface this question by saying our thing of the day, we always have like an article or resource or something that we talk a little bit about. And I really loved your blog post on autism. I think it's called Autism, Sleep, and what's the last one? I got to scroll up all the way to the top of the article. Autism, ADHD, and Sleep, an expert guide on neurodivergent sleep. And you have like amazing tips. A lot of them I knew, but then there were a few things that were completely like, oh, I really should do that. I really should, I mean, one of them I already knew I should do is like not do work in my bed, not watch TV in bed, save it for sleep. But you go through so many aspects of sleep. But I'm hoping that's what we can talk about it, or like, what are the things that we can do? And you have a beautiful visual too about sleep supports in 6 different buckets.
Mm-hmm. So my brain needs to put things in context. So I do buckets a lot. I talk about different. Oh, and interesting. Actually, I got into sleep research when I was in the oncology clinic. So that comes full circle to earlier. There's a lot of different sleep buckets. And my one huge umbrella thing would be to rule out co-occurring sleep issues. So if it's, like an organically based insomnia disorder or sleep apnea, right? Mm-hmm. So after that, assuming that there's clarity that there's not like a organic medical thing going on as well, walking through, kind of the 6 sleep buckets, first to identify like, okay, where is my sleep? Like, what are my sleep triggers kind of? So is it that I get hyper focused at night and I stay up late, or is it like sensory things, or is it a busy mind? So I think first figuring out like, what are your sleep triggers? And then figuring out what supports based on that. So sleep hygiene, like this is kind of, if you think about body hygiene, it's the equivalent, but for sleep. And I think there's reasons why sleep hygiene is a bit harder for a lot of us, but it's kind of that classic, like we should be sleeping in a cold, dark, quiet room. And then we want to think a lot about what associations we have to the bed. This gets into one of the buckets, which is sleep stimulus. Mm-hmm. I love this because it's getting into like the science of sleep. And this gets back to like our brains build associations. So what is the association your brain has to your bed? With the insomnia loop, a lot of people will associate bed to stress. And so there's a lot of different practices to break that neural pairing and to build a new neural pairing where you associate the bed with sleep. The stronger that association is in the mind, the easier it is to fall asleep.
That is so cool.
And then another one of the buckets is cognitive strategies. My favorite is something called cognitive shuffling. And that's something you can learn in like 60 seconds. And that's the one that I consistently use. It's like the one thing that'll help me fall back to sleep when I wake up in the middle of the night.
Do you want to tell us what that was? I really like that it's like less visual than some of the other strategies. Because I can't always keep visuals, like move things in my mind. One of the strategies I know was something like that, but the shuffling, and you made a point of mentioning the shuffling is good for people who don't always think in images.
Yeah. So a lot of us have aphantasia. And so like the inability to see images. So cognitive shuffling, if you do have images, if you are able to see that, I think it's even stronger when you use images, but you can do it without. So cognitive shuffling, and there's an app that will walk you through this. It's called My Sleep Button. And that it's a free app. Last time I checked, it's free for iPhones, but maybe it costs for Android. But essentially, it's the idea of shuffling your thoughts to the point that they're no longer linear. And this does a couple things. One, if we are prone to rumination, we can't effectively do that and ruminate at the same time. The other thing it does is it actually mimics the first stage cycle of sleep. And so it brings us into kind of a headspace that predisposes us to sleep more easily. So if you wanted to do it on your own, it's basically like take a word like rainbow or garden, and then take the very first letter of the word. So let's say we're doing garden. You would take the letter G, and then think about all the words that start with G. So good, garbage, gallery. If you do see images, you can pair that with an image. For me, I do, because it makes it a little bit busier, and I have a very busy mind. So I need to also imagine myself drawing that image. Yeah. And then when you expire with the G words, you'd move on to A. Airplane. Oh my gosh, I can't think of other A words. Apple. Yeah. And so that's cognitive shuffling. And then naturally, your mind's going to get distracted and probably start thinking about something, and you just gently catch it and then redirect oh, I'm on A. And you go back to A.
Until you tire yourself out. I love that.
Unfortunately, as you did that, you said garden, and I think I had read the blog. I went, oh yeah, and started going to G. I want to go and get a dictionary.
You're a completionist.
Yeah. Well, but it also logically I'll go, I know it can't be complete, but that's not a technique I think that would work for me. But also that's not to disregard. That's just a thing for me that I would. So I've shared this story before. When I had my diagnosis, I woke up in the middle of the night realizing that I had been given a 20-step mathematical problem. Maths is pretty easy for me. And I realized I made a mistake on step 2. And I wanted to ring my psychologist right away and say, I made a mistake in step 2. And the real answer is this. That's how much of a completist I can be.
That's strong. That's strong.
Very strong urge.
Fortunately, my wife said no. Because it was it was 2:00 in the morning or something.
Thank goodness for Meredith.
I think that every single day. In fact, probably every single hour.
I think that too. She's amazing. Okay, so that's a great strategy. I'm going to try that because maybe that'll help me fall back asleep. So that's one on my list to add to all the things I'm not doing.
Sorry, may I interrupt on this one? And this is a genuine story. This is not a criticism, but it struck me sometimes. Bed is a wonderful space for me. I love my bed. I actually jump into bed and do bunny kicks, which is my feet are doing this.
That's so cute.
I really do love it. It's a very safe space. It's an intimate space in all the ways. I mean that word. And so when my wife and I go to bed, it's just us. And we've got teenagers and cats and work and things, but we sort of close the door in bed. It's just us. We have a very strict routine. We'll read. Meredith will be on her phone. I'll have my iPad and I'll be reading an article or looking at soccer results or, not research work. But then we'll go and watch a television show and she'll cuddle up to me and fall asleep on my chest. And that's every single night. That's the way it happens. But it's breaking this. There's always television. There's always electronic devices. And yet, if this doesn't happen, often Meredith can't get to sleep. If I'm sick or we're grumpy at each other for some reason, there's no bedtime cuddle watching television, she won't fall asleep. And it's okay, so how do we balance that? No television, no electronic devices, but in fact, this actually is something that's worked for us.
And turns off the brain chatter.
Well, and this is, we just don't know enough, right? about, oh gosh, I would love to see studies on this.
Mhm.
Like I find in general for self-care stuff, neurodivergent folks have to play and experiment and figure out what works for them. So it sounds like you and Meredith have found what works specifically for her. Um, and that doesn't surprise me that sometimes like that there might not be the classic experience. And especially countering like our very busy brains. My son and I actually have a joke. So even though he's older, he'll often ask to sleep with me, and he'll sleep better. And I actually often sleep better too when he sleeps with me. And we've joked like, oh, we're body doubling sleep because
Oh, that's interesting. And I just say again, and again, this is just my personal experience. I don't think either of us, the times that we don't sleep in the same city, we neither of us sleep because we need to body double. That's I'm going to tell her when she comes home. That's exciting.
Amazing.
the other thing I hear is you have a routine, like you have a really clear routine around bed. There's the cuddles, there's co-regulation, there's the show, there's the screens, and routine is that's another one of those buckets. So even though it involves some screen, it's very boundaried, it sounds like, and it's very routine based. Whereas like for me, I will sometimes, and this is where sleep hygiene, I think gets tricky for a lot of autistic people. Our bed can be our refuge. So I'll sometimes work in bed.
Yes.
I'll notice that when I do that for a long time, I'm more likely to start waking up at night. Like, and I can tell that like, okay, I am developing a more like hyperactive relationship to my bed. But that's a trap I fall into because it is so comfortable to work in bed.
Yeah. I like when I get home, that's all I want to do is go to bed, cuddle a cat, then do everything else there other than like cooking and all that kind of stuff. But I'm going to try to move to the couch for things. We'll see. I'll report back.
Please do. I'll be curious. Yeah, that's kind of I have started to move more of my work to my couch, and I've noticed it's helping. But yeah, I think experimentation. So I think there's plenty of folks that might be like you and your wife, where it's like you can watch a show and it doesn't get, especially if it's part of a routine, it doesn't overly disrupt.
I think it's hard to, in the world that we live, in which we live,
in a world where these things happen.
Yeah. What was I going to say? Oh my goodness.
Sorry.
Tangent gone. No, I think it's hard because sometimes we don't get to do the things that we like to do to relax until quite late in the evening. You have to do chores, you have to cook dinner, you have to do all the things. And then it's 9:30, 10 o'clock, and that's when you can first catch up on an episode or really like unwind doing one of those things as an interest, which makes it hard too if you're trying to like have at least an hour before bed without any screen time.
Absolutely. There's a term for this. I always mess it up. Revenge procrastination sleep or something like that. It comes from ADHD literature. But yeah, that tendency to like, because I didn't get to do what I wanted throughout the day, this is like revenge procrastination on going to sleep.
That's amazing.
Makes a lot of sense.
Sometimes I will get like very angry about like, I can't go to bed. I need to have my personal time. And so that must be what you're talking about.
Mm-hmm. Exactly. Especially like, I know for me when I was parenting young children, I had a lot of that because it was like, this is the only alone time I'm having in my whole existence.
Yeah. I'm kind of mad at myself as a child. So when I was a child and it was time for naps, I would be so upset that I was being told to go sleep. And now I'm like, I wish I could have naps more often. But yeah,
unless I was really sick, I didn't have a nap between the age of maybe 8 and I think it was like 40 or 41. It was the very first time I had a daytime nap. Mm-hmm. And now I'm I don't know, I'm getting old, see, but I feel at 3 o'clock in the afternoon now, I feel I could go and have an hour nap and it would be a good thing. But all my life previously, no. And it's actually, you've just raised a point about the routine. I'm just wondering, in my previous relationship, I didn't have that routine.
And how was your sleep?
I have no idea.
Okay.
And again, we're getting to this fundamental problem is like, how's my sleep? I don't know. I wasn't falling over. I wasn't sitting at a keyboard and falling asleep during the middle of a gig. So fine. How do you know? How are we supposed to know what good sleep is?
I think, and everybody's body's different of like what they need. I don't have the research in front of me, but like for some people, like they function quite well with 6. Other people it's 8. Other people it's 9. I do find, I don't know how reliable it is, but like I know when you can do this on the Apple Watch, or I think I first did it with the Fitbit. There's a way to measure sleep quality. That was the first time I was like, why is my sleep quality so low? I think it was probably measuring something about REM sleep. But again, with more kind of biotech devices coming out, I think there are ways to measure sleep quality, and there'll be some data around like you're in this percentile. And so that can give some feedback, I think.
I need to do this.
I'm not sure if Apple Watch has that or not. I first did it on the Fitbit, but I would think Apple Watch would have something like that.
Yeah.
Percentile. What does that actually mean? And I think this is one of the problems I have with lay discussions about sleep. There's this idea that you're supposed to sleep between 6 to 8 hours a day. I think that's kind of the numbers. And I think similar numbers to that you've just mentioned. And then there's was it Winston Churchill who like proclaimed he got through on 4 hours of sleep every night, and there's some people at 10. And I recognize there's a very, very amorphous population and what the numbers are. But like if you find that you are 15% less REM than neurotypical, what does that mean? Is that important? Or is that just me?
I think it's important in the sense that like we know what sleep does for us, but I think that's where I'd go back to like, well, what is a person experiencing? Like for me, sleep is a struggle, and I experience a ton of fatigue and cognitive fatigue. And so like I can point to data points in my life of like this, I can tell this is what it's costing me. Mm-hmm. If someone came in and they're like, I'm getting 5 hours, I feel great, I don't feel fatigued. And if I was pretty sure they didn't have interoception issues, then it'd be like, okay, that works for you. That works for your body. So I think that's where we really have to contextualize it of like, is this working for this person or is it not?
Yeah.
And again, we're fundamentally at you've articulated several times during the podcast, you have struggled with sleep. And I think that's always going to be my question is how do we learn that? What is that? Like, how do we learn what that means?
I mean, sometimes other people talk about being refreshed, and I just never know a difference. I don't know.
Yeah, I would think there'd be like some data points we could look at. So like a common question is like, do you wake up feeling refreshed? Right. So if someone's saying no to that always, I think that would be a marker of a sleep struggle. How many times are you waking up at night? When you wake up at night, how long do you stay up? If someone's frequently waking up at night and if they're not falling back to sleep right away, that I would say that's a sleep struggle. How long does it take you to fall asleep? On average, it takes autistic people, I think 11 minutes longer to fall asleep. Again, what's normative, but if someone's taking 30 minutes to fall asleep or an hour to fall asleep, that's a long time. I would say that's a data point of a sleep struggle. So I do think there's ways we could quantify it and say like, yep, if these data points are there, you get to say you have sleep struggles.
Yeah.
But then it goes back to the relationship. Do you experience your relationship to sleep as a struggle? Mm-hmm. For me, I do. So I will own sleep struggles. So it's subjective. And I think it's also, we can quantitate it as well.
Yeah. Oh my gosh. Because of my conversation with Bruce a few weeks ago, where he said, like, I think there's other possibilities besides, just never going back for a sleep apnea test. I did talk to my doctor, and he said, do you want me to prescribe you something? And I haven't taken anything. Because he also said, like, it's addictive and you don't want to take this medication more than twice a week. And it's like, so even if I did start taking it, I would only have 2 good nights of sleep. Like, there's got to be something else besides meds. So I love that now I have more things to try, because I've done a lot of the sleep hygiene. I think most of us kind of know what we're supposed to do, whether or not we do it perfectly. But yeah, cognitive shuffling might be the key.
Yeah, let me know. Give it a try and let me know how you like it.
Yeah.
At the core of all of this, I think is, and I'm harping on the same questions because I think this is the autistic, the very strong autistic part of me. It's like I think this is information that needs to be shared with our community. That there is such a thing as good sleep. And it's, you should be looking for these data points. And in fact, I think I've never heard the points of what worry points of sleep would be before in such a clear way. Yes, you do need to get this PDF.
I can't wait for the PDF because I'm going to take that to my family doctor.
Okay, I'll bump it up in my priority list.
With all the other million things I'm sure that you have to do. So,
and that would be a great thing to include in there. So thanks for that idea, Bruce, of like, here's markers that you're struggling with sleep. Like you're waking up X amount of times. It's taking you this long to fall asleep. It's because you're right. Like we only have our experience. And so unless we see that data, how are we going to know if it's worth looking into? So yeah, I'll add that to the PDF.
Exactly. Because I had kind of given up trying to look for solutions. And then it might even have been you, Bruce, but I've talked to a few people about this who said, like, the amount of times you wake up is not good. It's like, really? Yeah. Okay. This is unusual.
You and I have talked about this before. Okay. And I would never have said it's unusual, but it's like my gut feeling is you waking up 10 times a night. That's not good.
Yeah.
Regularly.
Yeah, that's not good.
Yeah. I told my therapist, and she made a comment that I'm sure that she thought was helpful. And generally, she's always helpful. But she said that it puts me at risk for dementia later. So now that's something I can think about when I wake up 10 times a night.
Yeah, that is part of the sleep stress cycle. Is once we start learning about why sleep's important, we can get stressed out about not sleeping. That's where the cognitive CBTI for CBT for insomnia. I don't normally love CBT for autistic people. CBTI is one of my exceptions. I actually think that that's a great resource for insomnia because it helps with kind of addressing those anxious thoughts.
But generally, I'm pretty chill when I wake up all the time. So
that's a lot. Yes. Yeah. Yes, that is a large amount of wake ups.
So this podcast episode was not just for our listener benefits. It was mostly for mine. Well, Megan, it has been so wonderful chatting with you and having you on to talk about these things. And I'm so excited to learn more from you as I listen to your podcast, and hopefully we get to chat again sometime.
Yeah, likewise. Thanks so much for having me on. I love how organically we dove into what I thought was really interesting conversation. So thank you both for having me. It was really a pleasure to meet you both.
Yeah.
Thank you. Example of bottom up thinking, right?
Exactly. I feel like all of our last episodes have all really connected. We had someone on talking about bio-wearables, which came up today, like just like the through line. I feel like we see the Matrix all the time. And in listening to your podcast, I think in your first episode, you talked about how it's like, how do you end things? It's so hard to end a podcast. Usually we ramble.
End with the awkward goodbye. Patrick, because he can actually synthesize. I don't synthesize information well. Many autistic people struggle with that. Yeah. So Patrick will usually synthesize, and then if I say anything at all, it just makes it awkward. So I've just learned to embrace the awkward goodbye because it's true in my normal life. So why wouldn't it be true in podcasts?
absolutely right.
This is definitely another topic of a podcast. This is something I've got a couple of posts ready to go about how to finish, because it's part of my I teach a lot of composers, and one of the most important lesson to teach like an experienced composer is knowing when a piece is finished.
Can we transfer that to life? Is there a life lesson?
I think we're discussing exactly. I mean, I was articulating it very specifically from music, but it's quite true. And then I was thinking about my own pieces are actually just a single possibility of an infinite possibility space.
Well, okay. Tangent. I know I already was like, bye, but we're not
Bye,
done.
everybody. But Bruce has just dropped a bomb.
Tangent. Okay, so Bruce, you do know this story, but I once, not, in the last couple of years I was dating, and I broke up with someone. I had like a long walk in the park to break up with someone, and I used my exit line, like the line I had prepared in my mind, as like, this is when it's over, and then it just didn't end. And then there was like this long, awkward, I don't even know what, like it got really, really awkward. And finally, like I didn't know how to end it because I'd used the line already. And I had to say something along the lines of, I think it was like, so what do we do now? Do we just like walk in opposite directions? Like, how do we get out of this graciously? And like, 'cause I didn't know what to do. So how do we end this graciously?
Oh my gosh, that would be a great PDF or resource of how do we end things. And
like,
I love
you
that.
need to always like flow chart another possible ending. I think that's what I took from that.
Yeah, and have like multiple exit strategies.
Yeah.
I'm going to synthesize just for a second here. I think we got to get off this topic because I want to keep on talking about it. And I know how do we end a podcast. My family's just got home and it's dinner time.
There we go.
You know what? I would say
necessity.
30% of the time we end because you have a reason to leave, Bruce, which is also a great strategy.
And please, I don't plan that.
Yeah, it just works out. Well, thank you so much, Dr. Neff. It's been amazing talking to you. I really, really enjoyed this.
Absolutely. So great to be with you both.
All right. Take care, everyone. We'll see you again sometime.